Thank you.
We're going to turn now to Dr. Jamie Hope, who's coming to us from Oakland University William Beaumont School of Medicine. She is a keynote speaker and an invited lecturer across the country on a variety of medical and health-related topics, and we are thrilled to have her joining us today. She has a special interest in physician wellness, resilience, stress management, and healthy habits. So it's really good that we have someone with her expertise to talk to us about a very traumatic topic next. She's talking to us about resuscitative hysterotomy. Dr. Hope.
Thank you so much for having me. Before I start my slides, I just want to express my appreciation in the opportunity to get to be here. I know with the pandemic, we had tons of changes, and on one hand, some people are feeling a little zoomed out, but in a lot of ways, it's been really beneficial. And the reason that you see me twice here on the panel is not because I have an evil twin. If I did, she could help me with laundry at least. But so I had this going on my computer and then also on my phone so I could do other things. And I found if I'm trying to multitask and do things that take some level of cognitive load, like email or even social media, I don't pay attention and I miss those awesome pearls that these great speakers are dropping. But I can hop on my Peloton and fold laundry and still learn. And I found as a squirmy, active, kinetic ER doc, I learn better if I'm moving. So there is some benefit. I absolutely miss in person. I'm looking forward to a both and in the future, because I think my residents would think it's a little weird if I drop and start doing sit-ups and planks in the back of lectures in between talks. Zoom, this whole thing also gave me permission to get an awesome stand-up desk and purchase an absurd number of plants for my office. So I didn't have to be depressed during the whole Zoom thing. So anyway, let's get started. Unfortunately, this is not the most lighthearted topic, but it's incredibly important. I teach a lot in pregnancy emergencies, so postpartum hemorrhage, coding of a pregnant patient, and then this specific focus is going to be on the resuscitative hysterotomy. And every time I teach this, I always worry that the shift gods, either the day before or the day I teach this when I go in before after, are going to give me one just to prove that you've got to have the skills. So that is why it is incredibly important to practice. I worked yesterday evening. Instead, the shift gods gave me the scariest pediatric airway I have had in 15 years, for real. However, I work at one of the biggest, level 1 trauma centers in the country. Just I didn't get that. Siri, butt out. My watch is being weird. Sorry. Like many of you, very well resourced. So I was able to get PEM, the PICU doc, ENT, anesthesia, and everyone in the room was sweating. But I also work at a rural critical access hospital, which is a 3-bedroom ER, and the nearest doctor help is a 45-minute lights and sirens ambulance away. And that's why I love to teach these, high acuity, low occurrence type of procedures, so we know them like the back of our hand. So some things you can look up, right? You can look up some pressor doses, you can look up something about pancreatitis during a shift, but when someone's crashing in front of you, we don't have time. So making these really simplified cognitive tricks to help you remember these when you are at your most panicked and most scared makes such a difference. So let's get started. Yeah. And here we go. Sure. There. Okay. So this is when every second counts. And I love this quote. I read it in Never Split the Difference by Chris Voss, who is a former FBI hostage negotiator. So had to work in the same kind of high stress, high stakes environment like we do, where lives are truly on the line based on the decisions you make. So I remember this quote often: you don't rise to the occasion, you fall to your highest level of preparation, particularly in the most stressful situation. So like with a lateral canthotomy, we learned numb, crush, cut, cut. And with the crike, we learn knife, finger, bougie, tube. I want to offer you that same level of simplicity here today. So you'll see my slides are intentionally unfancy, very austere, very simple, so that when this possibly once in a career lifetime procedure happens in front of you, you will be ready. The other important thing is, because these are lower occurrence but such high acuity, it is really important to have spaced repetition. So I set aside time on my calendar once a month where I just go through these crashing, incredibly critical procedures. And then we do that with our residents as well, where we revisit it on a regular basis. But because maternal mortality is on the rise, women are having babies at older ages and with much unhealthier overall medical pictures, the odds of this occurring are actually going up. So there is a good chance that you will see this. And so when you're in the room, you will be the expert and that calm person who performs this procedure accurately. To be clear, I do not expect you to be calm on the inside. That sounds very frightening, but on the outside, you'll go through this procedure quickly and easily. The procedure itself is actually quite easy. But why do we even do this? Does anybody survive? And it makes such a difference. So we've got some older case series as well as some newer data coming through. But the survival, the infants that survive, and they're talking about neuro intact survival, some level of functioning to fully neuro intact, which makes a difference. And the huge key here is the vast majority of the survivors had this procedure performed within the first 5 minutes. So you don't have time to look it up. You have to know this, and that can make a huge difference for survival of the baby and of mom. Okay, so a couple things, just, timing of survival. Let's get into the procedure. So I broke this down just like numb crush cut for the lateral canthotomy and knife finger bougie tube for the Crike. This is your ABCDs of resuscitative hysterotomy. So A is the appropriate patient selection. If they are 20 plus weeks and they have lost vitals and no ROSC within 4 minutes, four terrifying, very short minutes, this procedure is indicated, period, knife in your hand, go. Now, 20 weeks, we've got a fundus up at or above the umbilicus. Those measurements are a little bit imprecise, but if you see a gravid uterus at or above the umbilicus who is coding and has no ROSC, you cut. The most difficult part of this procedure is making that initial decision, which needs to be done. Then it's take a deep breath and just do the BCDs really easily. So that appropriate patient selection, there's oodles of evidence from ACOG and all those type of things. So B is your cut. So big, bold, bone to bone. Big, bold, bone to bone cut. You're going xiphoid to pubic symphysis. We want to get the abdomen open as much as possible. Depending on how much subcutaneous fat, you might need to take a few swipes at it, but you need to get through that tissue and open up the abdomen as quickly as possible. We are not trying to make this look pretty. We can fix this later when mom survives and is hugging her baby at home and is less concerned about the scar that she has on her abdomen. Okay, so we're going xiphoid to pubic symphysis, big, bold, bone to bone. All right, next step is cut the uterus. So you still have the scalpel in your hand and you look for the lower portion of the uterus. You want to cut that with your scalpel. Don't cut the baby. So you're going to get what I call the gush and rush. So if you make it through with your scalpel, you'll get the gush and rush of all of the fluid that baby has been swimming in. That's how you know you're in. The next step is put the scalpel down. Now, there's a great case of a very successful resuscitative hysterotomy. Mom and baby both had great outcomes, but in the stress of the moment, the doctor continued to cut the uterus with the scalpel, kind of cut the baby stem to stern. They both survived, least of their concerns, but there's a safer way to do this. So you've already made your big, bold, bone-to-bone cut, stem to stern, cut the uterus, gush and rush. Now put the scalpel down somewhere safe and get out your scissors. You're going to put your fingers in the hole that you created, put the scissors on top of your fingers, and let your fingers be the guide to keep it safe from cutting the baby, and cut the uterus wide open so you can get this baby out. So that's your gush and rush, okay? D, deliver the baby. See, this procedure isn't as complicated as it sounds. Head first, of course, mind the cord. Just because all these other things are going on is not protective for things like a nuchal cord. So you still want to check, and we're doing everything we can to try and deliver this baby intact. So mind the cord, reduce any type of nuchal cord, clamp, cut. And in an ideal situation, in this very non-ideal patient scenario, we want to then hand the baby off to the NICU resuscitation team so they can go forward and resuscitate the baby while you can concentrate on mom. However, there are situations, if you're single coverage, where you need to also work on resuscitating the baby. You want to have the team continuing chest compressions on mom, anything you can do to help with the baby. At this point, if you can deliver the placenta, great. If not, the appropriate thing to do is to pack everything with sterile towels. You can even throw a staple or two in the belly to keep it closed. You still want to be able to open it to assess for bleeding. Throw a towel over it, continue to resuscitate the mom as appropriate per the algorithm for CPR, of course, and resuscitate the baby through the appropriate protocols. So this is another important thing. So this is the S, the little s. So you want to stop the bleeding, of course. So anything you need to do as you're packing that uterus, if you need to give it a little pressure, you want to do that. Make sure you are not inadvertently compressing either the aorta or the IVC, because that will worsen your resuscitation. So you're going to pack or press it carefully, of course, and the scalpel and scissors and the stones to do this procedure are really the only tools that you're going to need. Scalpel, scissors, stones. It's scary, but the procedure itself, as I've said, is very easy. Let's talk about some evidence-based medicine around this, because with all this going on, we are so used to doing a bunch of other stuff, assessments, things, cleaning. And in this situation, I'm going to tell you, don't waste time on these things. We're going to cut them completely out of this algorithm. They are not necessary. Prepping the skin. Now, I've seen this in situations, even someone throwing in codes and lines and stuff like that. The way that betadine works is it has to dry in order for it to be effective in reducing infections. So wet betadine does nothing except for make a mess. So I know you're going to be tempted to want to grab a bottle of betadine and hose it all over the skin and make a huge mess before you do this incredibly successful procedure. But it's not important. It's not going to work because you're not getting that drying time. So we're ignoring science. And now we've made a mess. If mom survives neuro intact and gets a little bit of an infection from you cutting the skin, great news. That's the least of her worries, because we can provide antibiotics. That is something that is very, very easy to treat relative to this very, very difficult to treat situation. So no prepping the skin, don't make a mess. This is an emergency procedure. As you can imagine, there's not time to obtain consent. This is covered in terms of legal, that this, even if the father of the baby is present or anything else, you do not have to ask, you don't have to discuss it. This is a go, 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 because again, as we mentioned, every second counts. Assuming mom has been getting excellent compressions from a witnessed arrest the entire downtime, the placenta is still getting inadequate perfusion, particularly if the uterus is compressing the IVC, and during the code, nobody is displacing it and allowing increased blood flow, or if they put lines below the diaphragm where you're going to get that compression and get, like an IO in an emergency situation, decreased fluid, decreased resuscitation. So this is not the time. We want to maximize our CPR, and we want to just move forward with this. So consent is not indicated, and you will be legally protected for doing this. Now, like the other speakers here, I am an ultrasound enthusiast. So this is one of the most rare occurrences in all of emergency medicine where I would absolutely, boldly, unequivocally say, do not drop a probe on this abdomen. If you have an appropriate patient greater than 20 weeks who is coding, who has not achieved ROSC, what you need to drop on that abdomen is a scalpel, not a probe. Ultrasound is not therapeutic and will not resuscitate this baby. The quicker you get them out, you can assess their health and perform whatever you need to do to resuscitate them. But taking that additional time, no matter how fast and amazing you are, is still time with the placenta and the baby are getting inadequate perfusion. So I apologize, ultrasound gods. This is the one time we don't need you. By all means, use it for all of the additional things, even using it after the delivery to assess mom, to assess baby, and by all means, the heart rates of everybody else in the room, because they will be also freaking out. Waiting for OBGYN. This is an us procedure. They can also do it, but this is an us procedure. So waiting for them to come down, we have that fear. We feel like we need the permission, or this is their area of expertise. I wouldn't call OBGYN to do a crike. It'd be nice if we had some airway folks, but this is our wheelhouse. This is our lane. This is part of our resuscitation skill set. By all means, call them, because at some point they're going to have to put this person back together. That is definitely outside of my wheelhouse. I could suture it up, but it's not going to look as good. Then they'll see if they need to do anything else, whether a hysterectomy is indicated. That is the downstream medicine, but don't wait for them. If you have somebody available, to call them and let them know we're doing a resuscitative hysterotomy. That will usually get them to drop their coffee and run as quick as possible, but the procedure should be started or completed by the time they get there, depending on how big your hospital is. And this procedure is an anywhere procedure. Just like it's an US procedure, it's an anywhere procedure. This is something that would be indicated to perform in the field. Now, I don't know about you, I don't spend a ton of time in the field, and that sounds extra terrifying to not even have the staff there. But assuming, pandemic and dumpster fire aside, if you have short EMS transport times, they can be performing excellent CPR on mom. But if you know from your call ahead that she's already been down for more than 5 minutes, when they hit the door, you get the scalpel. This is not an OR procedure. We're not worried about it being clean. We're not worried about anything except for resuscitating the baby, resuscitating the mom. So again, this is, as you don't rise to the occasion, you fall to your highest level of preparation. So appropriate patient, greater than 20 weeks, CPR with no ROSC within 4 short minutes. Your cut, big, bold, bone to bone. Big, bold, bone to bone. You're going to cut her wide open. And you're going to use that scalpel to cut the uterus, get your gush and rush, put the scalpel down. Cut the uterus, not the baby. It's the scissors you use for the uterus. Deliver the baby and the placenta, mind the cord, just like in any other delivery, and then stop the bleeding and continue the resuscitation of both. So, all right. Also, for the record, I hope none of us ever have to do this, but as I mentioned, the rates of maternal mortality from other causes are on the rise. Dissection is huge. More than a huge proportion of dissections in women under 40 are pregnancy related. There's increased risk. Cardiovascular death, medication deaths. We have older moms, sicker moms, diabetics. So this is a potential, and that's going to be part of our career. So I hope that helped give you a little bit of comfort and a quick mantra to fall back on if this ever comes through your door.
Thank you, Dr. Hope. Only an emergency physician, I think, would feel compelled to ask forgiveness from the ultrasound gods after suggesting that an ultrasound has no place in a specific procedure. I like that. And that was really important today with all of our ultrasound gods on the—
I know. I don't want them to smite me and send me one of these procedures. So,
Dr. Hope, I have a question for you from the audience. This is from Che, who asks, can the uterine incision be done vertically or horizontally?
No, so in this procedure, you want to just go straight up. This is a the incision with the scalpel, yes, that doesn't matter. Gush and rush and make your hole, whatever, that shape doesn't matter. And then when you cut the uterus with the scissors, you're going straight vertical.
Okay, so the majority of the cut for our purposes, both skin and uterus, is going to be a vertical cut.
Straight up and down, yep.
Okay, excellent. Well, thank you very much.